Hello and welcome to another episode of Low Tech Health. Let ourselves translate expert knowledge. I'm back after taking a week off. I missed a day, forgot a day, and then took a couple days. So here we are. And I had a week full of double episodes. And I've realized something. I've never mentioned my blog, I think, in this entire podcast ever out loud. I publish every day a little bit of knowledge, and I used to put in some excerpts of a book I'm working on lowtech.home.blog, lowtech.home.blog, if anyone ever wants to look at it. There's a lot of pictures. It's kind of cute. Let me make sure I'm saying the right actual, what I say, lowtech.home.blog. Yeah, that's real. Let ourselves translate expert knowledge. We're back and talking about healthcare and how we really need to reevaluate our camera angles, what that means to us in this country. And I just had the craziest idea, honestly, and I'd like to start with it, about making pulmonary toileting a national protocol. What is it? I want it to be a household name. Pulmonary toileting is breathing. That's what pulmonary means. In CPR, the second part of cardiopulmonary is the lungs. Most important part in the ICU because we go airway, breathing, and then circulation. It's important to do compressions, but eventually the body will run out of oxygen, which a lot of times in critical settings, oxygen is the most important thing to help people. And that is what is happening to patients who get COVID, is they lose their ability to perfuse. They drop oxygen and we call it desaturate. They dry out, they desaturate. They don't become soaked. And it's such a weird word to start thinking about, saturating. Are they saturating well? Are they saturating their body with oxygen? Because it's not just how much we can pump in, it's how much you can exchange, which, love kombucha. Pneumonia blocks that perfusion. It is literally just extra stuff in your lungs. You're going to get stuff in your lungs. That's going to happen. But you get it out through pulmonary toileting. It is not a sexy name. We might need to rename it. It might need to be something else. But it is the most important thing to get this gunk. It looks like cheese. It really does. It looks like thick cheese. And it looks like that on the x-ray too, which I'm not allowed to see at this facility. Kind of weird. They don't let the RN see the x-rays in this hospital in the West. Yeah, there are a few things that are a little different about the way they do things here. And on this Meatless, Eatless Mental Mushroom Monday, can't forget to say that. I want to bitch. Excuse me. I want to complain. I want to bring to everyone's attention the importance of pulmonary toileting, which is getting out that cheese in your lungs. We do this through several methods in the hospital, especially really good ones. You provide the patient, as soon as they're extubated, really as soon as they're admitted to the hospital, I provide them with an incentive spirometer. Also not a very sexy name, and it doesn't look really cool either. I need to figure out some name for it. I wish I had an audience. I really haven't been doing much of a podcast because one of my biggest fans I'm living with, she hasn't watched any, so she's seen me all the time. Taking a little break, but sorry to my fans out in the South. I'll keep up this week. 20-minute episodes. This is going to be a good one, long one. So, getting out the gunk through incentive spirometry is using a little device that is basically the thing at the circus, the game at the circus where you swing the mallet and try to ring that bell at the top, but you're doing that with your lungs. You put this little a hose, this hose microphone piece to your lips and suck in, and everybody wants to blow. Everybody does. As soon as they put it to their lips, they think that's not what we want. It's good that you have a little bit of force out, but the most important thing is how you're pulling air into your lungs through the use of your diaphragm and through negative pressure. Because the way this incentive spirometer works is the opposite of what your lungs are doing. So as this negative space is being filled with this little device that rises like the thing at the circus that rings the bell, because it's a concealed shut vacuum. Not concealed, just sealed. You can see it. It's the point. You got to see it rise. I think there needs to be a bell at the top. There really does, or some kind of flashy something. We need to remake it. I don't care if this gets stolen. I hope somebody sees this and remakes the incentive spirometer. I'm on board, man. I want everybody doing it in the entire country. What I thought is what we could do is put this little device where patients are usually intubated, and it's still important once they're extubated to get them an incentive spirometer. You really want them to clear that stuff out, because we're basically just titling shallow breathing normally, and it's about taking deep breaths to fill your inspiratory reserve volume in your total lung capacity, not just your vital lung capacity, but your total lung capacity. We need total coverage. Do that, expand the very bottom and the top, expand them all. It's lovely to see. There are very cool diagrams that show how lungs expand with ventilation, because we've done it to cadavers, because you can see it, and then you can see how a collapsed lung needs extra, what's called PEEP, positive end expiratory pressure, and that keeps air in the lungs as it blows the second breath in. So it keeps it at what's the measurement? I think it's like milliliters per deciliter, something like that. I think it's just milliliters, actually. Let me see. I'm very curious now. I've never been more curious of anything in my life. PEEP measured. Diffuse acute diffuse functional capacity this is true. PEEP. I'm right for PEEP. Yeah. Centimeters of water. That's right. 10 centimeters of water. Interesting. I don't know why I've never really looked at that. Most clinicians selected PEEP 5, 8, or 10. PEEP was 50 or less. Most stuck with 5 or 8. Above 50, stick to 10. Yeah, that makes sense. So anyway, PEEP, positive end expiratory pressure, keeps the lung inflated as you blow that second breath, that third breath, each breath in, keeps it inflated to a certain centimeters of water. Very interesting. This is about volume. It's odd that it's measured in water. It's because I'd like to study how the ventilator works and have another episode on how it's actually being used to use centimeters of water to push oxygen in there. Oxygen in Batman. This incentive spirometer, when patients are intubated, needs to be above them, right? Like not above them where their head is looking up and they can't see, but that position we usually put patients, head of bed up, and like so, and they're looking up, and there's a point over just above that direction, and we need a shelf in every hospital bed, in every room, where they're looking at it just beside the TV. That's right, and we need them to ask, "What is that?" If they're not immediately shown what it is, but there needs to be a pedestal that this incentive spirometer is put on. Because if we get people doing it, man, they'll get better. They do. Pulmonary toiletry can be sexy. I don't know how to relate it to Meatless, Eatless, Mental Mushroom Monday, but I'm eating carrots. I ate a carrot today. That's all I've eaten as far as full. Actually, no, I ate some chicken. Yeah. What are you going to do? Make it a Mental Mushroom Monday, mental side. Why do we call it health care if we're not going to make it patient-centered and really get them involved in the team? Because healthcare is a product that we're all going to buy, even if we don't plan to. You better buy it earlier than you have to. You're being told what happened to you. I don't know if that rhymed. I feel like that may have rhymed. I've been getting better at that. Freestyling. I'll stop whispering. 10 minutes. Shows where my peak is. I've never gone past this point, or it's been a while. The first episode I went 15 minutes. Run out of material. Nah, not run out of material. Just need to practice talking to myself. I'll get more guests on here eventually. Figure it out. There's not a whole lot of placed upon this. Really easy going. Kind of hard to follow. I know. So let me tell you about my night last night. I had 2 super cool patients. They really were getting along awesomely. Once in a quad from congenital disease. Congenital? Yeah. That he's had from birth. So he's bedbound and real pleasant. Trach pegged. He's got full 9 yards. But he's not on any pressors or anything sedative. He just needed the ventilator because when you're mostly torso, which is what happens with quadriplegics, your limbs atrophy and they don't have any flexion action. He had a little bit of non-purposeful movement kind of with his cough, but other than that, he was unable to move his head above. He's smiling, real pleasant. His teeth looked great. They're very yellow. I wonder. Yeah. But I love mouth care. Appreciates it. And man, do I love brushing a good mouth. Toothpaste and everything. Pulmonary toileting. Even with your trach and peg patients. Very important. Super duper important. And I just... I'm trying not to complain too much. There's just such a difference between having good protocols that initiate things that prevent ventilator-associated pneumonia, that help put the patient kind of centered in the care, as opposed to solving critical problems and then moving on would be awesome. And I miss that. I came from a pretty strong hospital that put on a lot of hands. A lot of hands went into that care, and the physicians, the resident physicians, were aggressive and hungry, and such a wonderful team. I miss them all so dearly. Even though I was float pool, I didn't really know any of them very well because, again, they rotate. They're not always on the same night. I'm never on the same floor, basically. So it's hard to get accustomed to them, who they are. But there was no difference between their ingenuity and their appreciation of nurses and their dedication to the patients. They did a lot of bedside care, and I miss that. Because the physician-led care here is just lacking. There's not a whole lot of hands-on in the room assessment. Oh, they round on the patient. There's no involvement. Few words are spoken. There's addressing of the critical patients. Very critical, but a lot of things just seem to go by the wayside. And I don't know if it's something that is going to continue past COVID, or if this is a consequence of COVID or not. Could be just the way things are done. I've only worked at 3 hospitals. I've only really been in 5 hospitals. 3 of them were owned by the same organization, but everywhere has their problems. There's just such an importance on pulmonary toileting that you'd think you'd be on the same level, because the mental gymnastics that happen to not set your patient up for doing a job when they're able to. Granted, patients are intubated, cannot participate in intensive spirometry. I did have it a couple times where docs would ask me to use an intensive spirometer on patients with trachs, which, yeah, it's important. This guy who came to the hospital with fluid overload, and this quad is covered. He's not covered. He's filled with just feces because he's impacted and his stomach doesn't move much. He's got no peristalsis to speak of beyond about probably right here-ish. I don't know. And like it's just, he's got peristalsis. Peristalsis is where your body moves food through your gastrointestinal system. But I don't. He's not utilizing it, and who knows how much of a bowel regimen he was on. He was full of stool, just full of it, so much that his suprapubic Foley wouldn't work, or suprapubic catheter. His catheter inserted into his bladder above his genitalia because of the neurogenesis and the lack of strong tissue and the tendency for infection through that whole tract and the wreaking havoc that it has on the body, the brain. But where's I going? I've been up all night, by the way, and this is tonight 4 of 6. Yeah, and it's awesome. Love this job. I love hard work with good people. We got some strong nurses, real strong. Literally, they're all very strong, and I don't think this gives me away. It's like where I am in the West, but they're predominantly of Filipino descent. It's like it's like a calling that the culture has embraced fully, and it's made some pretty strong nurses. And they all speak, of course, the language, and they talk very fast, and it's amazing how that importance of communication is, because like sometimes we'll have patients who are like Hispanic, and like I'm not Hispanic, Cassidy isn't either, but she's been able to understand a patient a little bit better with their accent than them. There's this barrier. It's interesting how the ear picks something up better and interprets it faster. She had a patient who's speaking Spanish first to her. He's very hypoxic post-COVID, or he's post-extubation. He's still mid-COVID. Trying to work on his piss-poor pulmonary toileting, who's saying things in Spanish first and then English, because he's realizing that, oh yeah, she speaks Spanish. I'm not talking to my native tongue. Who is this? Where am I? Why can't I eat? Man, such mental gymnastic to not just set up a patient to do a job well once they're extubated. It really set us up for success. We need to make pulmonary toiletry the sexiest thing in the hospital. And I think we can put it on a pedestal. We can put some shit spinning. And we can get things done. Thanks y'all for listening. I'll see you tomorrow on Let's Talk Tuesdays on Taco Tickers. Wait, come on. Let's Talk Tickers on Taco Tuesdays. Thank y'all for listening. Bye-bye.